So when he came to us, he reported good adherence, although he did mention that he does sometimes miss his evening doses. And for a period of time at the end of 2000, that in the end of 2017, he accidentally stopped his boosted PI, or maybe just the ritonavir portion of it by mistake due to a misunderstanding from his other provider. So there's definitely some adherence concerns. Other than his antiretrovirals, he takes sertraline for depression, tamsulosin for BPH, zolpidem for sleep, tramadol for aches and pains, and then he's on daily Bactrim. Okay, so he hasn't been at UCSD for all of his care. So it's a little bit difficult to get a good ARV history from him. He only remembers being exposed to many different antiretrovirals in the past. He does recall being on zidovudine monotherapy when he was first diagnosed in probably the early 90s. And then what we do know is that sometime up until 2010, he was on Truvada with twice a day darunavir ritonavir. And then in 2010, 2011, he was intensified to Truvada, raltegravir, etravirine, and darunavir ritonavir. And then in 2014, basically the raltegravir was changed to dolutegravir. And so obviously, when a patient presents with a regimen like this, no matter what you know about them, you obviously are going to suspect that there's a significant amount of drug resistance, right? He's on multi-class with a bunch of different antiretrovirals. So pretty complicated situation, probably. When we first saw him, these were his labs. CMP was pretty much unremarkable. He does have elevated triglycerides, not much to speak of with the CBC. And then over here, you see the trend in his viral loads. So going back to 2015, up to most recently November of 2017. Really, obviously not getting much benefit from his antiretrovirals. His viral loads in the tens of thousands pretty consistently, despite maybe questionable adherence. But I think when you see a viral load like this, you're assuming this is probably more than just adherence, and probably a contribution of resistance. And then if you look at his CD4 count over time, been low. So high hundreds, low 200s pretty much consistently without change. And if you actually take this, you could take this back. I think we have lab values going back several years. It looks pretty much the same for many. So what we knew about his resistance history, this is one of the resistance tests that we got. So let me orient you to those of you that aren't used to looking at resistance tests, and it's a little bit blurry, but this is from 2008. So they list the names of the drugs here by class: NRTIs, NNRTIs, and protease inhibitors. Then they list the resistance mutations, so the mutations that are suspected to cause significant drug resistance to the different antiretrovirals. And then over here, they will list per the company that does the resistance test monogram. That's their interpretation based on those mutations, whether the drug is sensitive or resistant. And so some things to point out, and remember this is 2008. So on this resistance test, he does have some activity left of different agents. So it's hard to see, but these mutations, M41 and 215, are called TAMs, or thymidine analog mutations. So these are very common in people who were exposed to AZT or stavudine in the past. So those mutations are signatures of being on those drugs in the past and developing resistance, right? So that's why they're called thymidine analog mutations, because those are thymidine analogs. And so when you start developing thymidine analogs, it does cause reduced sensitivity to pretty much the entire NRTI class. He also has M184V. So most of you probably are familiar with M184V, but that is a mutation that causes full resistance to emtricitabine and lamivudine, and means that at some point he was also either non-adherent or on a suboptimal regimen with those medications. But tenofovir is still determined to be active at this time. For the NNRTIs, he has mutation K103N, which is likely due to a period of time of failing either efavirenz or viramune, nevirapine. And the only drug sensitive in this class at the time was etravirine, which is a second generation NNRTI. And then he does have some protease resistance too, already in 2008, but at the time darunavir was still sensitive. So it makes sense that he was on probably Truvada with twice a day darunavir or ritonavir. I also included over here from 2008 is a tropism. So for those of you not familiar with a tropism, basically that tells us if one of our HIV medicines, Maraviroc, is active or not, or will work or not. So for Maraviroc to be active, the virus needs to use R5 as a co-receptor only to enter the cell. So his virus uses X4, which basically means that we can't use that drug either. So this is 2017 now. So this is when he came to us. We got a resistance test, a genotype. And so you can see significant changes, right? So this looks a lot worse than the one that he just had. So some of the changes, he's got, it's picked up an additional couple, 1 or 2 thymidine analog mutations, as well as the M184V that's still present. So per their interpretation, the NRTI class is pretty much resistant. Interestingly, he's now acquired additional NNRTI mutations. So particularly, it's hard to see, but this is a Y181C. That's probably because he was not adherent to etravirine once they put him on that drug, or it was suboptimal regimen, couldn't suppress him. So he started developing additional NNRTI mutations. So now, essentially, based on these 4 drugs, this class is also gone for the most part. He very concerningly also has now developed integrase resistance, right? So that first resistance test didn't show integrase. It was from 2008. So this resistance test does. He's got multiple integrase mutations, 4 different integrase mutations. So, you know, he was on raltegravir and dolutegravir, so it happened sometime when he was on those medications. And concerningly, he has 140 and 148 combination, which is a bad combination to have for integrase. Causes a high fold change in activity of all of the drugs. And then also really concerning is that he's got a couple major darunavir mutations. So his exposure to darunavir has now led to additional darunavir resistance. So by their call, darunavir really isn't probably doing a whole lot. So you can see his options are now pretty limited on what we can use. So I put up here the Stanford database interpretation. For those of you that aren't familiar with the Stanford database, so what this is it's a website you can go to and basically put in all of the mutations someone has, analyze it, and then basically the website will give you a report based on the mutations, what they determine they think will be sensitive or resistant based on those mutations. And so they break it down by class. And so if you look at the NRTI class, which is up here, they're calling tenofovir low-level resistance, but still partially sensitive. And it's hard to see the score down here, but this is a scoring system. Basically, they give you a weight of each mutation and how much that might affect sensitivity to the drug. And then they give you a total score. Basically, as a reference, if this total score is above 60, then that's considered fully resistant to the drug. So tenofovir score here is 20. So probably partially sensitive. In terms of the NNRTIs, the only drug that they say may have activity is etravirine with a score of 40. For the protease inhibitors, they're saying darunavir is intermediate resistance with a score of 50. And then hard to see, but all of the integrase inhibitors are considered resistant based on this database. So when we have someone that has this complicated resistance history, a phenotype might help, right? So phenotype will actually test the sensitivity of the drugs to the patient's virus to see not just if the mutations are there, but how much it actually impacts the ability of the drugs to suppress the virus. So we did order a phenotype as well. So this was ordered the same day as the genotype. And so this is a little bit different than the results from the genotype. So again, you have the list of the drug names. These are cutoffs of fold change. So the amount of drug it takes to inhibit the virus. Basically, what this is reporting is a fold change in that concentration of drug to inhibit the virus. So a higher fold change means it takes more drug because that virus has resistance mutations that makes it resistant to that drug. So they report the fold change here, and then they kind of give you a graphical representation of the fold change, and then based on that, their determination of if it's sensitive or resistant. So based on the phenotype, the one drug that may have activity is tenofovir. It's actually got no change in fold change. This is a 1. 1 is your baseline, right? So it's a 1 means it's sensitive. So maybe he does get some benefit from tenofovir. Etraviren's fully resistant based on the phenotype. And darunavir is really not contributing much. So you can't see it, but it's like a 60-some fold change in darunavir activity. And so 66-fold change. Above 90 is considered fully resistant for darunavir. So not much. In addition, down here is a phenosense integrase. So you can do the same phenosense for an integrase inhibitor. They're fully resistant. So almost max fold change on the integrase inhibitors. And then the last thing I want to point out is when you do a phenotype, you also can see it reports replication capacity. So replication capacity is, so when a virus has to maintain all of these mutations to make it still be able to replicate in the presence of these drugs, that's a cost to the virus. It doesn't want to maintain the mutations because it inhibits its ability to replicate efficiently. And so what they'll report out on a phenotype is how much fitness cost this is having on the virus to maintain these mutations. And so this replication capacity is 13%, meaning 13% of a wild type virus. So it's not a very fit virus, which could help contribute to some suppression. So, the phenotype shows maybe he has some drug sensitivity, but if you look at his viral load trends based on his regimen, he's really not getting much out of his regimen. Yeah. It's indinavir, crixivan. So we probably wouldn't go there with crixivan. Okay. So at this point, it's kind of like, now what do we do? Because we've got to try and figure out optimization of his regimen. So at the time, etravirine was dropped from his regimen because based on the phenotype and the genotype, it's probably not contributing much. The Truvada was changed to Descovy or TAF, right? One, for the obvious reason of the increased safety that we all know about with TAF versus TDF. But we'll talk about also that may have a resistance benefit in certain situations. And then we kept them on twice a day dolutegravir and twice a day darunavir because there's really not much else to do at that point, but continue those drugs, and maybe they're contributing to the fitness impairment that I mentioned, which could help reduce the viral load. So the real question is then, what's next? So some things that I think you could think about for a patient like this, one of them would be a drug called doravirine, right? So doravirine is an NNRTI that was fairly recently approved. It comes as a single tablet called Pefeltro, 100 milligrams a day. It also comes in a fixed dose combination with TDF and 3TC. That's called Delstrigo. In the trials, it was a well tolerated, mild side effects of nausea, headache, fatigue, dizziness, diarrhea. It's safe in renal impairment, although not studied in dialysis, and safe in mild to moderate hepatic impairment. It is a CYP3A4 substrate, but it's not a perpetrator of drug interactions, so it doesn't affect other drugs. It was the main treatment naive studies were Drive Forward, where they compared it against darunavir, and Drive Ahead, where they compared it against AAA. And it performed really well in treatment naive patients. But that's not who we're thinking about using it in. We're thinking about using it in the setting of resistance. And so I think the real question is, what is the resistance profile of this drug? And does it potentially have activity in our patient who has a lot of NNRTI resistance? So this is doravirine up here with efavirenz, rilpivirine, and etravirine, so the different NNRTIs. And what they're showing over here is the IC50, or the inhibitory concentration to inhibit 50%. And so the higher the bar, the worse. The higher the bar, the greater the impact of the mutation on the sensitivity of the drug. And then what you have over here is a list of the different more frequent combinations of NNRTI mutations. So I think the big one to point out is this combination of a K103N with a Y181C. That generally causes resistance to most of the NNRTIs. What kind of separates doravirine is that it seems to maintain activity with that combination of mutations. So our patient actually has that combination. Versus, say, efavirenz, rilpivirine, and etravirine, that combination of mutations really causes full resistance to those drugs. So maybe that's a situation where we would think about doravirine having an advantage from a resistance perspective. That being said, doravirine does have its own kind of unique resistance profile in that a single mutation at the 188 position, I188, causes full resistance to doravirine. So fortunately, that hasn't popped up on his resistance tests. So maybe doravirine would have activity for him. That being said, he's got multiple other NNRTI mutations. This is all in vitro data. There's nothing in clinical trials with resistance in doravirine. It's not been used in a population like this. So it's really, really hard to say if there would be actually a benefit from doravirine, but it's something to think about. And then at the bottom, they compare doravirine to some more unique rilpivirine mutations, like the E138K, and it seems to be active in that situation. This is, I think, one way we can kind of think about what might be sensitive or resistant is looking at the failures to doravirine, those that failed on the clinical trials, and what mutations that they have. So that's what this first box shows. These are patients who failed doravirine in the clinical trials. And when you look at what mutations, Y188L was the one I just mentioned, right? These all contain really a mutation B106, which is unique to NNRTIs, but that seems to be a common trend with doravirine failures. This second box shows that in patients who have a K103N, which is a mutation that efavirenz causes, doravirine maintains sensitivity, right? So it is more like a second generation NNRTI in that sense, that it maintains activity when first generation drugs have resistance. And then this other box over here really shows that when a virus is resistant to doravirine, most of the time it maintains sensitivity to etravirine. So there's not overlap per se or cross resistance between those two drugs. They seem to have a slightly different resistance profile, which might be a good thing from that perspective. So we thought about doravirine for him. The other option is this drug called Trogarzo, which is iberalizumab. And so Trogarzo is a monoclonal antibody that's approved for drug-resistant HIV. And the way it works is it binds to domain 2 of the CD4 receptor. So it's considered a post-attachment inhibitor. It allows HIV to attach to the CD4 cell, but it doesn't allow it to enter because it binds to this domain, basically. This is the generic name. This means absolutely nothing. It's just the FDA's way of labeling monoclonal antibodies now. They just add these 4-letter abbreviations on the end that don't mean anything. So for iberalizumab, the indication is to be used in combination with other antiretrovirals for the treatment of heavily treatment-experienced adults with multi-drug resistant HIV who are failing their current regimen. And this is an IV infusion, so it's given every 2 weeks. So the dose is a 2,000 milligram loading dose, followed by 800 milligrams every 2 weeks. So if a patient needs to receive this, they need to go to either the infusion center or get home infusion services or something like that to infuse the drug. So the studies looking at Trogarzo, there's really one main study with 40 patients that led to its approval. It's called TMB 301. It was a single-arm, multi-center trial that looked at patients who had multi-drug resistant HIV. So to get into the study, they had to have a viral load of greater than 1,000 copies and documented resistance to at least 3 classes of antiretrovirals. So this is a very experienced population, a lot of drug resistance. The overwhelming majority had very low T cells, most of them less than 100 T cells. So this is a small population. That's why there's only 40 patients in the study, but a very important group of patients who have very little options in terms of antiretrovirals. So these were the week 25 outcomes. So about 50% got suppressed. 43% were less than 50 at week 25, and 50% were less than 200 at week 25. And I didn't include any of the safety data up here because it is really well tolerated. There's not much to speak of in terms of safety of the drug. It does not affect kidney function or immune system function. There's no infusion reactions. So it's actually a really well tolerated drug, which is a good thing. So Most recently at CROI this year, they did present week 96 data for this trial. So they took the patients who had made it through week 25 and enrolled them into an extension, basically, of continuing Trogarzo through 96 weeks. And so the efficacy outcomes were good. I mean, it was the same. So all of those that achieved or were suppressed at week 25 maintained suppression through 96 weeks. So at week 25, there were 15 of 27 that were suppressed. At week 96, there were 16 of 27, so an additional patient. There were 5 early discontinuations. And they saw similar viral load reductions between 25 and 96 weeks. In terms of safety, the drug was well tolerated. There were no additional safety concerns between 25 and 96 weeks. 22 out of the 27 patients completed the 96 weeks of the study. This is the 5 that dropped out: 2 deaths, 2 consent withdrawals, and 1 physician decision. So again, it's a really small number of patients, but this is where our patient fits, I think, for options for him. The other thing I mentioned is TAF versus TDF and its role in patients with NRTI resistance. And so probably most of you know TAF achieves higher intracellular concentrations of tenofovir than TDF, about 4-fold higher concentrations. And so, the thought would be if you get those higher intracellular concentrations, it probably has more activity against viruses that might be resistant to tenofovir. And this is actually from CROI 2 years ago in 2018, but that's really what this study is showing. And so they showed fold change in sensitivity based on the number of TAMs. So this is looking specifically at patients with thymidine analog mutations with or without an M184V, right? So I didn't mention, but M184V, although it causes resistance to lamivudine and emtricitabine, it actually causes hypersensitivity to tenofovir. So it makes tenofovir more active. And so it's actually good to have an M184V from a tenofovir perspective. And so what they're showing is basically the fold change, both in site-directed mutants and patient-derived mutants, with different numbers of TAMs and then with or without an M184V. And so the takeaway from this is more TAMs is bad. So the more TAMs you have, so you can have 1 through 6, the more resistance you have to tenofovir. And if you have an M184V with the TAMs, that reduces the amount of resistance against tenofovir. And that's really what both of these assays were showing. I think most interestingly is a viral breakthrough assay that they did, where they basically used concentrations of tenofovir that mimicked either TDF or TAF, right? So TAF having 4-fold higher concentrations compared to TDF. That TDF is on the bottom here, TAF is on the top, and the red dots are viruses that broke through because of their resistance when they were exposed to the drug. And so for the TDF, which there were 15 viruses that had viral breakthrough, and most of those occurred when there was a greater than 2-fold change in sensitivity to the drug. For TAF, there were only 3 viruses that broke through, and most of those occurred above 6-fold change. And so what it's showing is that TAF has a higher barrier to resistance than TDF. And if you look at which populations had viral breakthrough, they were all patients with 5 or 6 TAMs and no M184V. So those are patients with a lot of NRTI resistance. And that was their conclusion, that TAF has a higher barrier to resistance than TDF. Interestingly, this paper here, what they're proposing is when you look at the phenotypes that we get and the sensitivity ranges of the drug, they're considering 4-fold change as the upper level of sensitivity for tenofovir, and that's really based on TDF. And so one would consider that if you get 4-fold higher concentrations of TAF, we should probably be thinking about upping that limit of resistance for TAF, maybe 4-fold. Maybe you can't extrapolate to that extent, but it's important to look at the fold change of the tenofovir and take that in the context of TAF versus TDF. So for our patient, between November 2017, September 2018, there really wasn't much follow-up for him until in September, he officially became one of our patients at Owen. And so at the time, we discussed continuing his current regimen of Descovy, dolutegravir, darunavir, ritonavir, and adding to it doravirine, Trogarzo, and Fusion, T20, until he was suppressed for basically as long as he can tolerate the T20, the Fusion, and then consider stopping that. Fusion, if you're not aware, and Fuvertide is a twice-a-day sub-Q injection. That's an entry inhibitor for patients with advanced HIV or drug-resistant HIV. And so the plan, so we tried to talk him into this at the time, wasn't super excited about it. He wanted to wait. He wanted to be super adherent, take all of his drugs, recheck a viral load in a couple weeks and see if things were better. Really, they weren't. So, these are the viral load trends from that point on. Basically, he's not even getting a log reduction in his viral load. It's still in the tens of thousands. So not much improvement. And then this is his CD4 trends over the same time. So again, stable, most recently down to 126. So low CD4 count too. So in January, we did intensify his regimen. He decided to go ahead with it. So we added the Fusion sub-Q twice a day, doravirine 100 milligrams daily, and then started ibalizumab or Trogarzo infusion. He did pretty well. He started developing injection site reactions with the Fusion, which when people start injecting it frequently, you get nodules, redness, soreness. It gets pretty uncomfortable because you're doing this twice a day injection. So we talked about it as a team at the time, and in March we said, okay, go ahead and reduce it to once a day. The thought was it's not recommended, but he's probably still going to get some benefit out of continuing it once a day. And then a month later, he said he was done with Fuvertide and didn't want to use it anymore. So he stopped that. Till today, he continues on Trogarzo 800 milligrams every 2 weeks with Descovy, doravirine, dolutegravir 50 milligrams twice a day, and darunavir, ritonavir twice a day. So these are his most recent labs. This is the viral load trend. So right here is where we started all those extra drugs. And you can see about a month and a half, he actually got to less than 20. So we got him suppressed. First time he had an undetectable viral load in about 10 years. This is where he stopped the Fusion, or where he decreased it to once a day. This is where he stopped it. He's been undetectable. June 24th, he had a slight blip in his viral load. We just repeated that 2 days ago, and it was back to less than 20. So, so far, so good. Unfortunately, but probably expected, not much change in his CD4 count so far. So this is his CD4 count, most recently 142. He's had a lot of years of low T cells, so not sure how much recovery he's going to get in his CD4 count. He's had no other significant laboratory abnormalities, no side effects since stopping the Fusion, and unfortunately still has some questionable adherence to his oral pills. But fortunately, it seems that the Fusion or the Trogarzo is definitely playing a role. Any questions about that patient? Yeah.
What about the patient 184 mutation? I recall back in 96, 95, Diane Hevler presenting information on monotherapy with lamivudine. And you quickly had a fall on viral load. And then after 6 months, you still had a half a log reduction. Mm-hmm. It was thought at the time that that it was a less fit virus. Is that still the thinking, that you still want to keep lamivudine, or instead of being on board to get that 1/2 log reduction?
Yes, so that's a good question. So the M184V mutation does affect viral fitness to a pretty significant extent. And so when we know a patient has an M184V, or we suspect a patient has an M184V, generally we actually purposely continue lamivudine or emtricitabine in the regimen. Those drugs are fully resistant. They're not really per se contributing to inhibiting the virus, but there's two advantages to continuing those drugs. One is this hypersensitivity to tenofovir that I mentioned. So you're getting more benefit from the tenofovir. And then two is the fitness impairment that the M184V causes, which causes a reduction in viral load by itself. We estimate about a half a log viral load reduction. So if you take emtricitabine or lamivudine out of the regimen, the virus will revert to wild type at that position. It won't express the M184V, and then you lose some of those advantages of having the M184V. So yes, you generally do purposely continue those drugs. Not to get too into the weeds, but you have to be very careful then what you think about pairing that with when someone has an M184V, because it does affect the overall sensitivity of the regimen for a patient.
Just to piggyback on the concept of the impairment of the viral fitness and replication capacity, you know, when this landmark study from the ACTG came, one of the issues that people thought is because the initial replication of the virus is heavily dependent of the interlink of the nucleotide in the reverse transcriptase of the virus. It probably makes sense.
Mm-hmm.
The integrase inhibitors work at a different level when the initial explosion of replication and fitness is driven on them. I'm seeing a different concept now that sort of imply that perhaps keeping fully resistant integrase inhibitors will have some effect on replication capacity.
Mm-hmm.
Do you have any in vitro data or anything about it?
No, that's a difficult thing to know. So when you order phenotypes, the replication capacity that they report is based solely on RT and PR, not integrase. When you order the PhenoSense integrase separately, it does report replication capacity on that test too, but that's based solely on integrase. And so it's hard to figure out a global perspective of how much the integrases are contributing to decreased viral fitness. I can tell you for him, you saw what his PhenoSense integrase looked like. His replication capacity was like 150% on the PhenoSense integrase. You don't know what his baseline was, right? So could that be a reduction from 200%? Not sure, but yeah, we've debated a lot in his situation if we should even continue the integrase and how much it's really contributing to his regimen. We were gonna think about starting to peeling off orals until he decided to stop the Fusion, and then we decided to leave all of the oral agents on. Okay. So this is our next case. I have 3 total cases if we don't get to the third. These 2 are probably the more interesting. So this is PN. PN's a 31-year-old transgender female who was referred to retro in October of 2018 for persistent low-level viremia. Her current regimen at the time was Biktarvy, bictegravir, emtricitabine, and tenofovir alafenamide. She had been on that since June of 2018. So 4 months or so. Sorry, this should be she, not he. Endorses a very good adherence. Can't remember the last time that she missed a dose. Her history includes hepatitis C, which is treated and cured, syphilis, and anal dysplasia. She's homeless, has ongoing injection drug use with methamphetamine and heroin. Her other medications include hydroxyzine for anxiety, ibuprofen, and Valtrex. And she's not on PJP prophylaxis because of the concern of photosensitivity. She's out in the sun all the time because she's homeless. So she was diagnosed with HIV in 2008 and started on treatment in 2010. Her baseline genotype was pan-sensitive. And then started on Atripla in 2010. And stopped the drug eventually a couple years later due to depression. She decided to self-discontinue. And then was off for about 2 years, and then for a couple months while in jail was restarted on Atripla, ended up coming off again due to depression for a year or so. Then in 2015 ended up starting Stribild. Was on that for a few months, then switched to Genvoya. And during this time, from 2015 to 2017, was really on and off her medication due to being in jail, ongoing substance abuse. Again, decided to stop for over a year, and then most recently restarted Biktarvy in June. So these were her labs at the time. So nothing too exciting on the CMP, slightly elevated ALT, AST, low white blood cells, low hemoglobin, and then these are her CD4 trends. So low CD4 count in the double digits. You can see when she restarted Biktarvy, her CD4 count was 3. So kind of bottom there for her. and has had some actually pretty good recovery since then, up to a CD4 count of 83 over the next several months. So these are the viral load trends and how they correlate with the drugs. So this is her baseline, and then she started Atripla here. Actually did pretty well on Atripla for several years. This is where she stopped. She did have this one viral load here before she stopped at 214. Was off drug here, and then right here, restarted Stribild. Never became undetectable on Stribild. Switched to Genvoya, really probably barely on drug at this time based on these viral loads, and then started Biktarvy here, and then this is what her viral loads look like since being on Biktarvy. So this is why she was referred to us, because she's got this kind of persistent viremia under 100, but in the 80s, 90s, to see what we could do about that. So we did a resistance test. So because her viral load was low, we couldn't do a traditional RNA genotype, right? Because you need circulating RNA to be able to do an RNA genotype. You need a viral load over 500 copies to do a genotype. She had a low viral load, so what we did was an archive resistance test, right? Which basically sequences the proviral DNA to look for archived mutations, mutations that have occurred and are in the proviral DNA. You do this when generally they have a viral load of less than 500 copies. So there's a really interesting resistance test, I think, that wasn't totally expected based on her viral loads being on Biktarvy. So a few things to point out. Again, what pops up is the M184V, right? So resistance to lamivudine and emtricitabine, but also she has a K65R mutation. So that's a signature tenofovir mutation. So that's what happens when you're not adherent to tenofovir, is you develop a K65R, and that generally has an impact on all of the NRTIs. And so it's additional NRTI resistance. I think what's interesting for her is that she has a significant NNRTI resistance. So K103N and another major mutation, that L100 mutation. What that kind of tells you is that this all probably started on Atripla. And so this definitely occurred on Atripla. This probably, the M184V, occurred on Atripla, and then maybe not the K65. That might have evolved later. But looking at the viral load trend, you probably wouldn't have guessed that there was a resistance to Atripla, but it definitely was. And I think that probably, because we had no resistance information prior to this, started contributing also to her failure on some of the integrase-based regimens. So the sad part is this extensive integrase resistance that's developed since exposure to the integrase inhibitors. So it's hard to see, but she has a Q148 mutation in combination with an E138, which again is a bad integrase combination to have, causes a lot of resistance to the integrase class. And then her PIs, fortunately, are fully active. And so it's really interesting to me, at least, that she was able to achieve a low viral load with Biktarvy by itself with this much resistance. So she has a lot of integrase resistance, a fair amount of nucleoside resistance, and still it actually technically kept her suppressed, right? Less than 200 is suppressed. And so it's interesting how much the Biktarvy held up in this situation. So this is her Stanford interpretation. So their Stanford database is calling tenofovir fully resistant, mostly because of having a K65R, but we'll talk about maybe that's not true in the setting of TAF versus TDF. And this is their determination, really high level resistance to most of the NRTIs. There's two NNRTIs that might still have activity. Again, doravirine comes up, as well as etravirine. And like I mentioned before, with doravirine, we really don't have experience in this situation, but it might still play a role in this situation. And then for the integrase, she's really got high level resistance to all the integrase inhibitors. So the plan for her was to stop Biktarvy. This is a really hard decision, actually, what to do, because you have someone demonstrating resistance to all agents in her regimen, but still with a viral load of 82. So it's hard to really say how intense you get with the intensification. For her, she was in a good place. She was adherent. She thought she could do it. So we did change to Simtuza, which is TAF, FTC, darunavir, and cobicistat. We added doravirine, and then we also kept the integrase on board because of what appeared to be a benefit from being on Biktarvy, but changed it to twice-a-day dolutegravir. I think the plan was to see what happens with this and then consider dropping the dolutegravir. So what happened with her viral loads? This is where we switched. A couple months later, she did get to not detected, and it was doing pretty good. She had come to 3 follow-up appointments. She had good adherence. She had a nice increase in her CD4 count with the change in the regimen to 158. We got her in our MAT clinic, the Suboxone clinic. She started on Suboxone, was getting off heroin, seemed to be headed in the right direction, and then in February got arrested. And so February of 2019, she was lost to follow-up. She was arrested. Just saw last week in the ED, she was released last week, was in the ED. ED notes mentioned she wasn't getting any of her ART when she was in jail. And so it's concerning because in a patient like this, it's a lot easier to go from here to here than it is from, you know, a high viral load in the tens of thousands down when you have that much resistance. And so hopefully we can get her back into clinic. So I mentioned the activity of tenofovir with a K65R mutation. This is from Croy. It's basically very similar to the study I talked about before with the TAMs. And they did another viral breakthrough assay comparing TAF and TDF. TFV is the in vitro form of TDF, basically. And so, again, you see similar results with the viral breakthrough assay when you have a K65R mutation. So with TDF, 10 of the 42 viruses had viral breakthrough, all at a fold change above 4, versus TAF, 2 out of the 42 viruses had breakthrough with a fold change greater than 8, causing viral breakthrough. So, you know, I think for her, you know, she was on TAF, she had a K65R, she also had the M184V, right, which causes this hypersensitivity. So definitely, I think tenofovir is still playing a role in the regimen. The other thing that a lot of the resistance information at Croy this year was updating some of our knowledge about bictegravir and Biktarvy in the setting of resistance. And so this was a study, so study 4030 is a phase 3 study that's enrolling patients and either keeping them on dolutegravir with TAF FTC or switching them to bictegravir. There's 565 patients and they're allowing any degree of resistance in this study minus integrase. So they can have NRTI resistance or NNRTI resistance, which is different than the other bictegravir studies. So they categorized the patients into 3 groups. They either had a K65 or greater than 3 TAMs, that was 5% of the patients, any other NRTI resistance, which was 19% of the patients, and then no NRTI resistance, which was the majority of the patients. So they had historical genotypes from 285 patients and archive genotypes from 377 patients, and then 14% of the participants had an M184V. This is early results. This is week 12 data. The study hasn't even been unblinded. So this is both bictegravir and dolutegravir data, but it's a 1-to-1 randomization. So you can assume about half of them are on bictegravir. And so really the results are really good. So, you know, high viral suppression rates across all groups, including 97% in those with a K65R or multiple TAMs, 98% in the 81 patients with the M184V, which we still ask ourselves, is bictegravir the right choice in that situation? And then they actually had 20 patients with integrase resistance that they found on the archive genotypes, and all of them achieved suppression. And so that's positive, but really early, only 12-week data. The other, I think, interesting poster is the one that looked at long-term efficacy of bictegravir in patients that had archived pre-existing resistance. So this looked at 2 studies, 2 large bictegravir studies, and went back and looked at the resistance that they detected on archive resistance testing at the initiations of the study, because although they weren't allowed, patients weren't allowed in if they had documented resistance, they were allowed in if they didn't know they had resistance because they did archives on most of them. And so there's 445 patients, about 1.3% had a K65R, 10% an M184V. And then you had patients with NNRTI and PI resistance, relatively small number. There was also 6 patients that had integrase resistance detected. So over here, you see the virologic outcomes. So the blue is those without resistance, 99%. Anyone with resistance was 97%, and those with an M184V was 95%. And so, again, bictegravir with tenofovir, alafenamide, and emtricitabine seems to work pretty well in those that have at least moderate resistance. You can't see it, but they really looked at any predictors of failure based on resistance. So NRTI resistance, M184Vs, other classes of resistance, there were no predictors of virologic failure based on resistance. And then the last study I'm going to mention is a study that looked at patients who failed integrase inhibitors, so either raltegravir or elbictegravir, and they did in vitro sensitivities to the different integrase inhibitors based on those patients' viral population. And so the top box is, they kind of broke it into 2 groups. The top box is those that did not have a combination of 140 and 148, and the bottom box is those that did have that integrase combination. So if they didn't have that combination, they were all sensitive to either bictegravir or dolutegravir, and actually a lot of these patients had no INSTI resistance, which probably was more of an adherence failure than a resistance failure. If they did have the 140 and the 148, bictegravir and dolutegravir looked pretty similar in terms of their sensitivities to those viruses. The yellow is partial sensitivity, the red is resistant. And so their determination with this, that this supports looking at once-a-day bictegravir in patients with integrase resistance. Okay, we have a few minutes just for this last case. RA is a 61-year-old male diagnosed with HIV in the 80s. He was on a regimen of Descovy, Icentris, and atazanavir, who was referred for simplification of his regimen. The issue is that he had an elevated serum creatinine, 1.77. He had glucose and protein in his urine, and that didn't improve with the change from Truvada to Descovy. So the idea was from the primary was to see if we could move the patient off of a tenofovir-containing regimen. He did transfer his care to Owen in 2016, so we really didn't have many records. He has a history of seizure disorder, was on phenytoin for 10 years, but fortunately switched to Keppra, which really reduces drug interaction issues. He also has GERD in the past, but no longer on a PPI. And then these are his other medications. Nothing too significant in terms of his other medications. In terms of his ARV history, he's a poor historian. We don't have great details. We know that he was on AZT monotherapy, also DDI, didanosine monotherapy, stabidine, lamivudine. He's been on antiretroviral since 1999. Also thinks he might have been exposed to nevirapine, which is an NNRTI, and remembers being on indinavir. We know that up until 2016, he was on Truvada, Icentris, and atazanavir, ritonavir, and then was switched to Descovy, Icentris, atazanavir, ritonavir when he came to Owen in 2016. In terms of labs, I mentioned the elevated creatinine, protein, and glucose in his urine. Got a normal CD4 count, and what I'm showing you here is he does not have hepatitis B and an undetectable viral load. He's core positive, surface antigen negative. So let me rephrase, saying he doesn't have hepatitis B. He has exposure to hepatitis B, but he's surface antigen negative. So this is the archive resistance test that was done in 2016. This looks pretty simple from this perspective, right? He's got some TAMs, but otherwise NNRTI, integrase, and PI are all sensitive. So it would seem like a pretty easy switch. So if you base your information off of the archive, you'd be thinking about Juluca maybe, which is rilpivirine and dolutegravir, to take away the tenofovir component. So 2-drug therapy. But interestingly, he also has a phenotype from 2012. And the point is the phenotype picked up an M184V, the archive genotype did not. The phenotype also picked up NNRTI resistance, whereas the archive genotype showed no NNRTI resistance. This is concerning if you're thinking about switching someone to a 2-drug regimen that has an NNRTI and a integrase in it only, because this is a marker that he probably was not adherent to Viramune at some point, or developed resistance on a Viramune, and you have to question, does he have additional NNRTI mutations that aren't being picked up on the resistance test? And it even picked up some additional PI mutations that were not on the archive. So he actually has a fair amount of PI resistance. He's resistant to atazanavir for the most part, which is what he's on. But fortunately, darunavir still has activity, although partially sensitive. So the plan for him instead was to go with a 3-drug regimen of rilpivirine, dolutegravir with darunavir, so adding the darunavir. So the point of the story is that, you know, the presence of these mutations that were not picked up on the archive resistance test really does potentially change your decision on what to do with the antiretrovirals. And this is a comparison of his old phenotype from 2005 with the archive genotype. And so you can see there's definitely discrepancies in terms of the mutations that were picked up. And interestingly, this one shows a Y188 mutation in it too, which was not detected. So what this is a summary of concordance of DNA versus RNA resistance tests and the different studies available. To summarize it, basically it shows that there's quite a bit of variability between historical RNA genotypes and proviral DNA genotypes. So I think we have to be very cautious in interpreting archive resistance tests in patients who have extensive history. At CROI, they presented data looking at what may predict this concordance of RNA versus DNA genotypes. They looked at demographics, HIV parameters, as well as ARV therapy parameters, so old, how long they've been on ART and things like that. None of those seem to predict what a concordance between the RNA and the DNA genotypes. And then the last thing I want to mention is this study that was recently published that looked at how long a K103N persists in the proviral DNA. So they looked at 28 patients who failed efavirenz in the past and had a K103N, and they were switched to a PI-based regimen. And they had up to 10 years of suppression, and they sequenced the proviral DNA. 71% had a K103N after a median of 4 years in the proviral DNA, with 50% having persistence of the K103N for up to 8 years. So it does persist for a long time in the proviral DNA. They also did look at M184V, which tended not to decay over time and also was detected in the majority of samples that they looked at. And interestingly, the odds of detecting a K103N was almost 3 times higher based on higher viral loads. So higher viral loads at the time of failure to the efavirenz-based regimen meant it was more likely to detect a K103N later on an archive genotype. And we'll skip this one, and that's it. Any questions? Yes.
Thank you, Lucas. Great job. In that last patient, would you consider dropping the rilpivirine from the regimen?
Yeah, I think that would be, you know, he can probably just be on an integrase and a boosted PI, but he does have that one darunavir mutation, so that might be an issue. You probably still want to continue multi-class, and maybe continue all 3 classes given that situation.
I think it's relative to the last 2 patients. It's just a question that I don't know the answer. When you look at the sequence of clinical events, it's interesting that you show that the K103 in proviral DNA in 1 in 2 patients could persist up to 8 years, whereas with the classical conventional resistant test is 3.1 years only. So the question is, do you have any idea how long will an integrase inhibitor persists both in a standard and in a proviral DNA, because based on the sequence of exposures, that's a key questions that you want to answer before switching patients number 2 in particular.
Yeah. Well, I think how long an integrase inhibitor persists in a standard genotype goes to the question of how much it impacts viral fitness. And unfortunately, because of the limited amount of integrase resistance that we see, I don't think we really have a good sense of that. And it's kind of the same answer for the proviral DNA too. The answer is don't know.
Thanks, Lucas. The question I have is in regards to the second case, the transgender female that responded initially, I guess, was to Biktarvy, even though I wonder if she could have just different quasi-species that have very different, single mutations, perhaps, and maybe there's, multiple populations of different quasi-species, and maybe that's why she might respond. So my question is, are there any assays that can look deeper into specific quasi-species to kind of determine, are the resistance mutations exist individually, or is it linked on the same with the same virus?
Yeah, not really. The resistance, it's partially a question of to what percent of the viral population are you detecting in the resistance tests. And generally these standard resistance tests we're using detect down to 10 to 15% of the viral population. And so there is the ability to do ultra deep sequencing that can detect down to 1% of the viral population. Generally, the more sensitive you get, the more resistance you detect, but there's nothing that separates out different viral quasi-species, and with which virus is expressing how much virus is expressing different mutations, basically.
My take home lesson from your second patient is, for me, it was very interesting at first. However, you have a patient that is disenfranchised, has multiple risk factors for not being compliant. And she was very compliant. She was homeless, she was an IV drug user, and she was transgender. And these patients exist, and it's hard sometimes for us physicians to look at the positive side of some of these patients and give them a chance. And I'm glad you all did.
Mm-hmm. It's a good point, and she looks a lot like all a lot of the patients who end up are struggling with resistance and ART, and those are the patients who are failing, especially from a virologic perspective, but also from a social perspective, they really struggle to keep the viral loads undetectable. So and it's a comprehensive thing. I mean, I think you would notice that it's not just changing her ART, it's getting her into MAT clinic, and all these other things to try and help the social situation and help her be successful. So,
yeah. I don't know, are any of these studies use cystatin over ritonavir as they're like a base that in order to avoid that induction, because some induction that affects the volume's character.
That's a good point. Yeah, maybe. I mean, when it comes to our decision on cobicistat versus ritonavir, we're usually basing it on a convenience idea. And so for him, we wanted the twice a day Persista because he has darunavir resistance. And if you combine Prescobix, then it's not the right dose, right? Because it's 600, 100 twice a day versus 800 in the Prescobix formulation. Maybe you could think about using Tybos by itself. But we actually have some experience using Prescobix BID to help with adherence. Although it's higher darunavir levels, it's worked out well for our patients. We actually tried to do that for him, but his insurance rejected it. So we had to keep with the Persista-Norvir instead. But it's a good point.
It was also resistant to dolutegravir, so
it may not have mattered that much. Yeah. Thank you.